Good afternoon. My name is Dr. Amber Moyer. I'm a fourth-year resident at the University of Colorado, and today I'll be presenting the cost effectiveness of a dedicated feeding tube clinic. Thank you to SAGES for allowing me to present our work. I have no disclosures. Over 216,000 feeding tubes are placed annually in the United States, encompassing 24 different patient conditions utilizing products from 12 different major manufacturers. These tubes can be placed surgically, endoscopically, or radiographically by several different specialties, and they range in settings from bedside in the ICU to the operating room. Feeding tubes also come with a wide range of complications, including tube dislodgement, bleeding, buried bumper syndrome, peristomal leakage, infection, and long-term complications such as leakage, moisture, and hypergranulation tissue. This wide diversity surrounding feeding tubes often creates confusion for patients and their families as to who they should follow up with for feeding tube complications, often causing them to rely on the emergency department for management of these complications. But how often are patients with feeding tubes truly coming to the emergency department? Previous work in the pediatric population has shown that a high rate of patients require ED visits within 30 days of placement of their gastrostomy tube, with nearly 8.6% of patients in this population coming to the ED within 30 days. In the adult population, feeding tubes are often placed in high-risk populations such as elderly or neurologically impaired. And Rosenberger et al. Showed that each tube carries a lifetime accidental dislodgement rate of 12.8%, with the vast majority of these patients requiring an ED visit for assistance. And they found that each ED visit cost an average of $1,200. That encompasses the ED visit, the surgical consult, the replacement tube, and radiographic confirmation of tube replacement. So why is this important? Well, we place a lot of feeding tubes every year that come with a wide range of complications, and patients don't know who to follow up with, so they often come to the ED for help. To address this, we developed a dedicated multidisciplinary feeding tube clinic with the aim of providing patient and caregiver support and education, as well as prophylactic feeding tube exchanges and overall longitudinal continuity of care, and we wanted to see how that would impact patient outcomes. We hypothesized that this multidisciplinary feeding tube clinic would reduce costs related to feeding tube management. So a little bit about our feeding tube clinic. It was established in 2016. Anyone with a feeding tube can be referred to our clinic and enrolled at any time. We use a multidisciplinary approach, and the clinic is staffed by surgical faculty and residents, as well as dietitians, nurses, and a dedicated wound care team. At each visit, the surgery team performs a focused physical exam addressing tube concerns, and we also perform a prophylactic feeding tube exchange. Patients are provided with a replacement feeding tube to take home with them, and they also receive education on nutrition guidelines, tube care and troubleshooting guidelines, as well as 24/7 contact information. Here's an example of one of the packets that we send our patients home with. The middle page is all of our contact information, and you can see on the right the table of contents that we provide a lot of information on problem solving for things like diarrhea, constipation, or even how to unclog a feeding tube. For our study, we conducted a retrospective review of all patients that underwent feeding tube placement at our tertiary Veterans Affairs Hospital between January 2010 and September 2021. We used the VA Data Corporate Warehouse System to identify patients that had a CBT code related to feeding tube placement. And then we looked at demographics as well as feeding tube clinic enrollment and ED utilization and compared two groups, those enrolled in the feeding tube clinic and those that had received the standard of care. For our charge analysis, we used $1,200 as the average ED charge. That includes the ED visit, the surgical consult, the replacement feeding tube, as well as x-ray confirmation. And for our clinic visits, we used $350. That includes the office visit as well as the replacement feeding tube. For our results, a total of 104 patients underwent feeding tube placement during the study period, 18 of which, or 17%, were enrolled in the feeding tube clinic. The majority of the patients in our study were male, with median ages of 65 and 67, and median BMIs of 24. The most common diagnoses requiring feeding tube placement in our cohort included head and neck malignancy, neuromuscular disorders, malnutrition, and GI malignancy. When we looked at how often these tubes were getting exchanged and how often patients were having complications requiring an ED visit, we found that patients enrolled in the feeding tube clinic underwent significantly more feeding tube exchanges than those in the standard of care group. Patients enrolled in our clinic underwent 7.4 exchanges per patient over the study period, compared to those in the standard of care group who only had their tubes exchanged 2.7 times per patient, which was statistically significant. When we looked at ED visits, we found that 22% of patients in the feeding tube clinic group, compared to 53%, over half in the standard of care group, required an ED visit, which was also statistically significant. When we looked at the total number of ED visits, those in the feeding tube clinic group required a total number of 21 visits, and those in the standard of care group required 134, which is about 1.2 or 1.6 ED visits per patient, respectively, which was not statistically significant. When we analyzed why patients were presenting to the ED for feeding tube complications, we found that the most common presentations were for displacement, followed by malfunction, as well as leakage. Looking at the two groups, there was no statistically significant difference in ED chief complaint related to their feeding tube. For our charge analysis, when we looked at those that were enrolled in the feeding tube clinic group, these patients accrued a total of $25,200 in ED charges over the study period, compared to over $160,000 in the standard of care group. When we broke that down by patient, those in the feeding tube clinic group accrued about $1,400 per patient, and those in the standard care group was about $1,800 per patient, which is a 25% difference. So overall, feeding tubes come with a wide range of complications, and patients are often confused as to who they should follow up with, and they often then turn to the ED for assistance. Our study is the first to detail a dedicated feeding tube clinic that provides longitudinal continuity of care for these patients, and we have shown that this reduces unnecessary hospital utilization and results in a 25% reduction in ED charges per patient. One ED visit, the charges associated with that, is equivalent to 2 years of enrollment in our feeding tube clinic with prophylactic exchanges. So we believe that a dedicated feeding tube clinic not only improves patient care, but it also reduces unnecessary hospital utilization. In conclusion, we believe that this type of clinic with prophylactic feeding tube exchanges should be the standard of care at any tertiary care center that cares for patients with feeding tubes. Thank you.